Again, hopefully we'll have some open discussion time at the end, bring on the answer questions to that. And in the meantime, can we go on to Virginia's second case, please?
So this is another challenging case. He's a 48-year-old lawyer and with no past medical history, fully active. And then out of the blue, eventually he says he was fine, and he started feeling fatigue and fever, and he was pale. So he goes to the doctor, and they find in November, just like 15 days after he started feeling bad, this hemogram. As you see, he has 244,000 leukocytes with 20% blast in the peripheral blood and monocytes of 15%. He's anemic and he has normal platelets. The spleen is fine. So, well, this is the bone marrow results. He has 20% of blast. He has dysplastic changes going granulocytic lineage. And he has also in the bone marrow biopsy, he has 100% cellularity, 10 to 19% blast, CD17 positive, and CD34 positive. And well, we discussed this case because he has a high cellularity, he has a lot of immature forms of the granulocytic lines, and he has almost 20% of blast. So our pathology guys, they were very confused because he also has myelodysplastic changes, and he has monocytosis in the peripheral blood. So we discussed this case a lot. I think we have a smear. Oh, no, the smear is not here. Okay. So we were very confused. So my first question is, should we wait for the cytogenetic molecular testing before starting? Because we were thinking he has a very acute onset of symptoms. He has 20% of blast. It looks like it comes from a myeloproliferative disease, but we're not sure. And would you wait for the result of cytogenetic and molecular testing? That will take like 8 days at least before starting something?
I think when the high leukocyte count, 240 to 50,000, somewhere in that range, with 20% blast and the patient being symptomatic, I think we need to bring down that. The 922, I'm sure, is something that we will learn later. So when you present the patient, I think it's more like a dysplastic leukemia picture. And I would certainly look at cytoreduction, waiting for the results, because I think that's probably more important. And leukophoresis, hydria, cytarabine, I think these are all reasonable options in my opinion.
Well, he was critically looking, and yeah, we considered hydroxyurea also, but our colleagues, the pathologists, we discussed this case in our meeting, and they insisted that they think this is an acute myeloid leukemia. So we had PCR done quite early. We had a PCR able, PCR negative. So we thought, okay, this is not a CML. It looks like it's not a typical CML. This guy is looking bad. So we decided to go to an induction, to AML induction, 7+3 induction. That started in October 27. So at day 10, we got the karyotype. And the karyotype, we were in the middle of the induction, and we had this karyotype. He has Philadelphia positive karyotype. So we thought, well, this is a typical leukemia, and we asked for PCR for 190 and 230. I have never seen that one before, and actually he has a PCR positive for 220 and 30. type of CML. So it's a typical case. I don't know if you can comment on these cases, if you have seen them before, because the first time I see something like this one.
I've had one P230 blast phase CML. Actually, no, I'm sorry, I had two. And in both cases, they had someone following their chronic phase CML monitoring P210. So, you know, saying their response was excellent, because their BCR-ABL was undetectable every time they checked it. But then, you know, like the most recent one I had actually happened to be the one that I did the azavan asciminib with. And, you know, when she came to me, it was interesting because it was just none of it correlated, right? Her white count would be 60,000 and her BCR-ABL was undetectable, and it just, you just like exactly what you're doing here, saying this doesn't make a lot of sense, we have to look for something else. And so when she came here, we checked P190 and P230, and the P230 was positive. But more often than not, those tend to be more indolent. But obviously, as we're seeing here, and in the cases that I've had, are not always that way. Nothing is always textbook. So, but I think it just speaks to the importance of digging a little deeper when something doesn't perfectly correlate, right? Just because P210 was negative, you didn't stop there. And I think that is probably, to me, one of the most important things to point out about this case is, you know, even if this was morphologically a chronic phase CML patient, and you had cytogenetics that came back like this, and P210 that was negative, that right there tells you need to look a little deeper. And I think that, to me, is the take-home point, even though I don't think that's actually the question you're asking, but that's something I think we need to drive home.
Now that's a good point, because as I was staging this, you have a very unusual case, and I always insisted, I thought this was acromegaly leukemia, but when you have a P210 negative, you start, you know, doubting yourself. So I wanted to bring this because I kept saying, no, let's ask for the atypical forms, and it's not easy to remember to do that, insisting on that. So that's a good point.
Yeah.
Katia and Rafa, and then we'll move on.
No, just to share with you, Virginia, that this year I have a P230 case, but it was a patient in chronic phase. And the typical CML didn't have a dysplasia like yours, was a typical CML case, but the P20 and P90 negative, and then cytogenetic case, there was a translocation line. And then we went after, it had a P230 transcript as well. But he's in the beginning of the treatment. I don't know, and so far he's going well in the treatment. But it's funny because it was my first case too, with this transcript.
My question is for Virginia. I could not see the chromosomal changes in your patient. Do you have some compromise of the 5 chromosome or the 7 chromosome as myelodysplastic syndrome happens? Sorry.
No, just the Philadelphia.
Is it possible to do, I think it certainly is a very interesting case, and it's always challenging to differentiate them. Is it just a plain old CML with an unusual location, and or is it a pure AML or MDS, which is rare? MDS is much rarer, but AML with 922 is possible. But sometimes if NGS is possible, they may have other mutations, but not always is something that I would be available.
Yeah, that's a good point also. And Andres, it's saying that it's a good point. He doesn't have basophilia or splenomegaly, and why not doesn't have an AML with Phe positive AML, which was my colleagues from pathology, we discussed this point. why isn't it an acute myeloid leukemia with Philadelphia positive? So I don't know what you think about that. How you do distinguish between a chronic myeloid leukemia and blastic phase versus an acute myeloid leukemia with Philadelphia positive?
I think without additional mutations, either cytogenetically or by NGS, it would be very hard, in my opinion, to separate them out. In this patient, I think the dysplasia would probably be leaning, I would lean more towards CML because it's very unusual for CML to have dysplastic changes. There can be fibrosis, but dysplasia by itself, especially if it involves like all three lines, I would be more willing to call it like a myeloid neoplasm rather than CML in blast phase.
Obviously, it helps if you have labs from 6 months prior, a year prior, or something like that. Or I don't know if the patient has splenomegaly, maybe that leans towards maybe CML. But I think that distinction is really hard to make. And I don't know clinically how important it is versus more of like an academic question. Certainly we all, pontificate over that for a long time, all the time, but it's hard to make that distinction. I mean, I think what Vamsi said is totally right. That it'd be nice if he had labs checked 6 months prior and his CBC is totally normal, then that would also support AML, but.
I might say Soledad and then Carla, and then we really need to move on. This is a great discussion, of course, and it just takes a lot of time.
Well, I was wondering about the morphology of the bone marrow morphology, because if the bone marrow morphology was 100%, but with only 20% of blasts, I would rather think more in CML than in AML. I don't remember if he had a splenomegaly. If he had splenomegaly, no,
no splenomegaly.
That is strange with 200,000 of white blood cells. But I agree, sometimes it's very difficult to make the distinction. And I wanted to point out the importance of considering always the different transcript. I have had recently as a second opinion of a patient that had been more than 6 months or a year with dasatinib, and everybody was so happy because he had a P210, but they hadn't done cytogenetics. And so he was always, since the first check, he was, of course, undetectable disease. And so I suggested to stop the medication for a while and see if we could make a cytogenetics or FISH to look for if there was something different. And after that, after waiting for that, we had another molecular, and it showed a P230. And so, and the patient was in excellent conditions. That's why I suggested to, everything was normal, so I suggested to stop the medication and wait so the clone would come up a little.
Carla, and then we really must move on.
Just I have two cases, 230, but only chronic phase. But I am curious about the monitorization in these patients. I think that perhaps Virginia had treated with chemotherapy and TKI. I don't know why, I'm curious. But how to do the monitorization of these patients? We know that we need to see the cytogenetic, but how often you think that could be a good idea to do each year, each 6 months? How often to do the cytogenetic? My question.
So if you want, we can go on to the case, and then we can talk about the monitoring. Yeah, because of course it's on my plate. So we started at day 10. We started with dasatinib. We already had put all the 7+3, and the question I was going to ask you, Vamsi, is which TKI would you choose in this case? I have to say that in Colombia, for blastic phase, what we have approved is dasatinib in first line. So I didn't have any chance. But if you could choose between other TKIs, what would you choose? Would you think this is a best combination? What to do?
And I think dasatinib would be a reasonable choice. I wouldn't say that, obviously we can argue if ponatinib is better, but there is really no head-to-head between ponatinib and dasatinib. I mean, there has been data on imatinib comparison. Arguably, ponatinib is probably better, but it has more side effects too. And if we are going to take this patient eventually for a transplant, then dasatinib has a lot more data on post-transplant maintenance as well compared to ponatinib. So I think that that's why I would be okay with dasatinib if that's what we have available, and try and do that. If we don't have transplant, maybe then I would lean more towards ponatinib, just because we need something that is probably the best TKI there and accept the side effect profile there.
So we have all the cardiovascular events, and we did HLA, of course, and he has 2 siblings, but just an identical sibling. And this is the response. We started with a full dose of dasatinib, and he experienced grade 3 anemia, persistent anemia, neutropenia, thrombocytopenia. So we had to stop. He recovered from the 7+3, and then after recovering, he was all the time having this hematological toxicity of dasatinib. So he had to be suspended in December, and he had like 15 days to recover. And then we asked ourselves how we will monitor this, and how is the anemia due to toxicity or due to uncontrolled disease. So we did a bone marrow, and this is because I was taking out the drug, or trying to maintain dasatinib as long as I could, but then I did this assessment of response. And what curious was that the PCR was negative, the karyotype was negative, but he still has 6% of blasts and monocytes 10%. And so we were very confused about this, and scared also, because I don't have a donor right now. I can't take him to transplant. He's gonna take, the administrative part of this. So I wanted you to comment on these results. What would you think about that? Because he still sounds best.
What was the cellularity of the marrow?
It was good, like 50%.
I mean, is this blast percentage? Because it looks like the aspirate was 3.8. Was this just like regenerating marrow, or like trying to recover?
No, they were, well, it's like it's myeloid. So we always discuss with the pathologists, it's hard to say if they're real blasts, because they have no dysplastic changes or phenotype changes. So it's really hard to know.
Yeah.
But the thing is, he still has 10% of monocytes. So that, because it makes us very nervous. And he starts, if you see the hemogram, and now I didn't put it there, but he started having leukocytosis, but with monocytes. because he had monocytosis.
I think this goes back to my worry that the initial dysplastic presentation is more worrisome for more advanced disease. And I'm sure one of the drivers probably is the 922 with the P230, but may not be the only driver of the disease. And maybe that's what we are seeing here, because he recovered after 7+3 and then dropped the counts after that. So it doesn't, because he recovered the counts, then maybe I cannot justify that it is treatment effect always. And with the recovery there and subsequent dropping, it makes me worry that this is more than just a CML clone alone, and there is more disease. So the bigger question is how to treat this. Because of the neutropenia, I wonder if one question is, since the cellularity is normal, the question is, can he take another induction? Or the other option maybe is to buy time by treating with if he has venetoclax. I'm not sure if venetoclax is an option available, but that's something that we can consider, or just treat him as MDS with decitabine if venetoclax is not available till we get the donor ready and see if we can control the disease till that time point.
So I just decided to go to a second line treatment because he wasn't tolerating the dasatinib more than because of the response. I think I had to change because he didn't tolerate the dasatinib well. So I changed. So I decided to go to ponatinib, thinking about he's a high risk patient. He's not tolerating dasatinib. He's a atypical. So I went to ponatinib, and he's doing perfectly well with that. He has no hematological toxicity, no non-hematological toxicity, and his blood counts are well. He hasn't been transfusion. He hasn't had any hematological toxicity, and we're doing all the workup to take him to transplant as soon as possible.
Definitely agree the patient should be transplanted. I mean, monitoring, I would suggest PCR, P230 PCR, but obviously that was clear before the morphologic disease was clear. So like Vamsi mentioned, it seems like it was almost like the patient was back in like an MDS-like state after induction and dasatinib. I mean, I would say routine marrows and obviously monitoring CBCs, but I would still be monitoring PCR as well, because I mean, I suppose, if there's this CML clone and this like MDS, AML, you don't know which is which really, but it's possible, I guess, that the CML could almost come back as like a chronic phase CML, even if the MDS AML state of, I don't know, you may, like, if you see it coming back, you may want to start back on a TKI, but it looks like you've got two potentially unique processes going on, maybe. So
I think Carla is.
Did you do all the myelogram biopsy?
Oh yeah, the last one was in February. So I'm waiting this month. I will do another one to see how the dysplasia is doing.
So I'm so sorry, Rafa, we are not going to get to your final case today, but how about I make sure that we have Kendra and Vamsi have another look at your case and come back with any comments that they might have on it. I'm sorry, it was just such a good discussion. Anyway, sorry, amazing. Where does an hour and a half go to? But that's our time up for this session, I'm afraid. Thank you so much, Dr. Kendra Sweet, Dr. Rafael Hurtado Monroy, Assistant Professor Vamsi Kota, and Dr. Virginia Abello Polo for your excellent cases. Really excellent, and all your insight and wisdom. And thanks to the audience members for your contribution. There'll be lots of other questions that didn't get answered today. Please, please, please just send them through to me. If you send your questions to me, I will make sure that we get one or more of our experts to comment in that, and I will get back to you. So any further questions, any thoughts that come from today, send them to me. I'll get a response to you, and I'll get back to you as soon as I can. So at the end of our Latin American series of discussions, what's next? Well, once again, for those who aren't already familiar with the ICMLF Knowledge Center, I'd strongly suggest that you go and check it out. There is literally a wealth of knowledge in there. There are dedicated modules on CML therapy, management practicalities, TFR from the laboratory. There's the first tranche of a pediatric CML model there. The second tranche is on its way as we speak. I'm managing an advanced phase CML module that's almost ready to go, and a pregnancy one down the track. So there is so much knowledge in there. Please go and have a look and share that knowledge with your networks. If you really want to keep up to date with what's new in CML, then go and have a look at our website and sign up for the ICMLF newsletter. So if you sign up for our newsletter, then we will send you papers of the month. We'll keep you up to date with upcoming meetings or webinars. There are always links to summaries of conferences and discussions. Just go and have a look, sign up to the newsletter. Also on the website, you can engage with our interactive case discussion forum, which I mentioned earlier. And this is where people like yourselves will post difficult or interesting cases, and we take those to the key experts in the field and come back with advice or commentary. You might also like to join our social media outlets, Facebook, Instagram, or Twitter, whichever of those you prefer to engage with. And finally, since I've mentioned the ICMLF Climb for a Cure fundraising and CML awareness effort a couple of times, I'll send you a link for that too. Please enjoy. And if you're interested in participating, then get in touch. You'll be very welcome to come and join us.